Good evening, everybody, and welcome to tonight's webinar on dementia and palliative care and preparing for an expected death, understanding grief, and providing support in bereavement. My name is Rebecca, and I'm the Palliative Care Project Officer at Central and Eastern Sydney PHN. I'd like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respects to elders past, present, and emerging. I would also like to extend my respects to any Aboriginal colleagues who might be joining us this evening. So I've just got a bit of housekeeping to go through first. Please note that this webinar will be recorded and it will be available on CESFN's YouTube channel within the next coming days. Please submit any questions into the Q&A function at the bottom of your screen, and we'll be able to answer these throughout the presentations. At the end of the webinar, an evaluation survey will pop up on your screens, and a post-training survey will then be emailed out to you as well. And just a reminder that this event is approved under the RACGP CPD program for 1.5 hours of education activity and 1 hour of reviewing performance if attendees complete the follow-up questions and self-report. We do have quite a few events coming up, so please register via our website if you're interested in any. I'd like to welcome our first speakers for tonight from Dementia Training Australia. We have Dr. Peter Silberberg and Dr. Karen Savory. Peter is an experienced GP supervisor and medical educator. He joined Dementia Training Australia as a medical educator in 2022. He has worked in many primary health sectors and is currently working as a GP and is a lead clinician at Rekindling the Spirit Health Service in Lismore, and is also a GP at Lennox Heads Medical Centre. Karen is a Brisbane-based GP who works in clinical practice, residential aged care, and medical education. She is passionate about the education and mentoring of GPs, particularly in the area of aged care and dementia. She has worked with Dementia Training Australia to increase GPs' confidence and recognition and management of dementia. I'll hand it over to you guys now. Thank you.
Thanks, Rebecca. Let me share my screen.
Thank you, and thanks everyone for joining us tonight.
Hopefully that's moving along, Pete.
Yep, perfect.
So again, on behalf of Dementia Training Australia, we would also pay our respects to elders past, present and emerging, and extend that respect to anyone in the webinar tonight who identifies as Aboriginal or Torres Strait Islander. We're really pleased to be with you tonight. Dementia is something that we're passionate about talking about and about improving the lives of people living with dementia. So really we're looking at those, how do we work out who is moving towards end of life with our dementia patients, looking at what we can do as far as reviewing and rationalising what interventions we're doing, and very much having that person-centred approach. But what we really want to do is just be really practical and really think about how we can best support somebody living with dementia as they're moving into palliative care and then death itself. I'm just going to find where my Q&A went so I can see it.
While you mentioned that, Karen, we're happy to take questions as we go along. So please pop them into the Q&A.
Absolutely, because this is for you, so we want to be able to answer the questions that you actually have. And we do know that one of the reasons why we're talking about this is that traditionally dementias have often actually been not well looked after towards the end of life, mainly around lots of lack of education, lots of futile hospitalizations, and that increased challenge with identifying who's actually in pain, so that inadequate pain control as well. So some of what we talk about will actually be a lot of crossover with palliative care that perhaps you do for other conditions, but there's a few specific things with dementia as well. What we do know is our three kind of key messages is certainly when we're thinking about dementia and palliative care, we want to think about prediction side of it. how can we use that prediction to help us then prepare and then communicate either with the person living with dementia earlier on or with their families and carers as well. And certainly something as GPs, practice nurses, allied health that we should be able to do with or without support of some of our other colleagues as well. So Pete, do you want to say anything much about that kind of stage 1 and 2? I'll give you a nice graph to just at least mention the difference between the stages and which ones we're particularly thinking about when we're thinking about palliative care.
Yeah, thanks, Karen. So some of you may have seen this slide before that we've used. We use quite a lot in our education sessions, and it's a pictorial version of someone's journey through typical Alzheimer's dementia. So it will look a bit different for some of the other dementias, but this is specifically for Alzheimer's. And you can see across the top of the screen, we've got mild cognitive impairment, which is that potentially, if it's a prodromal dementia, mild cognitive impairment, that can potentially lead to a dementia. And then you go into what we've labelled stages 1, 2, and 3. And we've intentionally not called them mild, moderate, severe, because feedback we've had from patients living with dementia is that if you're in stage 1, no one considers that to be a mild diagnosis. And stage 2, 1, 2, and 3 better reflects this concept of a journey rather than a judgment on someone's capacity. So that's across the top, and then across the bottom is time. We don't actually have time written as a unit there, but it is over years. And then through dementia, there are 5 domains that we've talked about, which we might discuss a bit further forward. Cognition is obviously a very important one, and that cognition impacting function are the 2 important principles of making a diagnosis of dementia. And then there's also people's mental health, which often goes up and down post-diagnosis. And then the 2 at the end there are going to be really important for today's talk. So people's physicality and their function decreases through the journey, and they often have behavioural changes too, and that can either be in one direction, that's often called an agitated state, or it could be the other, where they become drawn. And so, but the end result with dementia is that it's a life-limiting illness, and that you die from dementia if you don't die from another chronic illness in the meantime. And so that's an important principle tonight, Karen, is for people to remember that it is a life-limiting illness, and that in terms of this concept of predicting and preparing, we can really use that to our advantage as doctors. Because we know what the end will look like eventually. And so today's talk, we're going to briefly talk 1 or 2 slides about stage 1 and 2, but really we're going to be focusing on stage 3, which is and particularly the last little bit of stage 3, which is the palliative part of the illness.
So right from that early stage, when someone is in stage 1, probably independent, still living at home, through to stage 2, where their care needs are kind of increasing, we certainly can predict that this is a life-limiting illness. We know that at this stage there is no cure for dementia, so we certainly can make that prediction at that point. And some of the things that we can do in preparation then is really thinking about dignity. How can we maintain their dignity, whether that's maintaining independence while they're still at home, or thinking about safety and dignity as those kind of needs increase, as that cognition and function drops, and really thinking about what are the things that bring the most quality of life at this point, those things that people really enjoy, and starting to think about those future plans, like where might somebody view that they may or may not like to be down the track, and that may not end up being possible, but starting to think about what that future might actually hold. And in fact, being able to document then as part of that communication is thinking about those enjoyable activities, what that advanced care plan might look like for that person, who would be their substitute decision maker, do they have family, neighbours, or are they very isolated and alone? So thinking about that, particularly in that stage 1 where somebody often has the capacity to make those decisions, it's really important to be able to get those wishes down so that we know what their wishes are. And in fact, if we know more about someone, if somebody comes into residential aged care and we actually know the things that they enjoy, then that can improve their quality of life as they transition into that next stage as well. So not only what their wishes are, but what they really enjoy, what makes them tick, what do they like? If we can have that documented, or somebody that knows that, that's really quite useful. When we come to
It's also
stage,
useful, Karen, because sorry, I was going to say it's also useful
yeah,
because as those activities in some that someone's deemed in as being quality start to diminish or even disappear, that helps us as doctors to be able to have that conversation with carers about the person's quality of life not being what it was, which are often difficult conversations. But if you know what that person thought was meaningful for them and that's now gone, then it's an easy conversation potentially moving forward.
when we come to stage 3, so we're really thinking about somebody whose cognition has significantly reduced. They're now probably fully independent, fully dependent for all those activities of daily living, needing 24-hour care either at home or in residential aged care, that sort of physical decline where they become more bed-bound, chair-bound, start having difficulties with speech, swallowing. That becomes a little bit trickier when we come to prediction. So if we look at this, you may have seen this graph before, but if we look at the blue line, that represents that kind of trajectory of somebody that has cancer, where they kind of travel along with all of the various cancer treatments until a point where either those treatments are no longer working or the cancer is over and they suddenly decline. The second yellow line is somebody that has a chronic disease, for example, heart failure, you know, emphysema, COPD, where they have repeated acute episodes and never quite get back to baseline. It's easier to see in hindsight often than at the time, but that very slow decline until suddenly that balance is tipped. The challenge with dementia is that very, very slow decline in the absence of an acute episode can actually occur over some years. So somebody can be in that needing, fully dependent for all cares, having significant difficulty with mobility, not being able to speak for a long time. So that prediction of where someone is in that stage 3 is a lot more difficult. So some of the things that we might use in general for someone to help us predict how their prognosis is, things like advanced disease, repeated admission, weight loss, pressure ulcers, that becomes a lot more difficult in dementia because again, those things can be there for quite a long period of time in that gradual slow decline. And obviously, if there is a sentinel effect, so if there is a fall relating with a fracture, urine infection, pneumonias, that may well trigger an acute event, which could be quite different. But in the absence of that, we know that it's definitely that much slower decline and much more difficult to actually predict. And some of the things that we might use as dementia-specific indicators also can be there for a very long time. So they certainly let us know that somebody is in stage 3, and often around that time I might be thinking, this might be months to years rather than years and years, but it is actually quite difficult to still make that prediction of where someone is in that journey. But when we see some of those things, we certainly can prepare. Do you want to talk about what you would do at this stage, Pete?
Yeah. So I think that question, asking yourself, would you be surprised if this person was to die in the next 6 to 12 months, is a good one to ask yourself. And if the answer is no, that wouldn't surprise me at all, then this is definitely a time to start thinking about preparing and some of these things to do. And I think probably the most important point we're going to try and ram home tonight is about, carer-centred, family-centred care. Just always touching base, getting back with the family where that's possible, whether that be via case conference or phone call or whatever means you need to do to bring them along, with the journey, because it's not really, I mean, like all illnesses, but particularly in dementia, it doesn't just affect the person living with the illness, it really does affect everyone around them too. So we need to think about that. Having some clear goals and, keeping the person's wishes in mind. So we've talked about trying to document quality of life and what that means to the person. And if they can't, communicate and recognise people in the room and they've stopped eating, then, they're usually some fairly clear indicators about that sort of thing. And just to keep going back and reviewing and assessing the situation, because things can move pretty quickly sometimes. But unfortunately, there's not sort of one prognostic indicator, is there, Karen? It's sort of usually a combination of things you have to look at.
So we certainly can determine somebody is in stage 3, but how long that stage might last is very variable, but certainly can be some years. And I've had families be almost surprised that, mum or dad or brother or sister actually has been in this same kind of what appears to be a holding pattern for quite some period of time, where they thought perhaps it might be much faster. So it is that part of that preparation is really those regular conversations with family and carers. The other part to that preparation is thinking about what actually are we doing with our medication. And some of that might be deprescribing. So starting to think about, what are the medications that are for long-term gains, but perhaps are not so beneficial now? Is there really any benefit to having somebody, for example, on a statin at this point? So really thinking about the medication burden that we're got people on, and really what, again, is it matching our goals of care? Is it looking at quality of life and comfort, or is it a preventative tool or something that is a longer term benefit? We might start thinking in this stage about some of that anticipatory prescribing. So if we think about what might send someone to hospital in one of those potential futile hospitalizations, is often staff not having the tools to use, particularly thinking about aged care, for things like pain or shortness of breath. Or so sometimes, again, having discussed with the family, you might actually think about having those prescriptions already there. And again, it's going to comes down to your residential aged care unit that you work with. Some of them are very comfortable and have that sort of impressibility, and some of them don't. But that anticipated prescribing certainly can reduce some of those hospitalizations and acute events. And then just keeping an eye on that change in care needs, as Pete had said, and notifying carers, families, if you're seeing more acute deterioration. Often get asked about defibrillators, and certainly if they are, the implantable defibrillators, definitely worth considering at this point turning them off. But pacemakers, which tend to be more common and what family are often worried about, are not going to change anything. So it is something that you can just leave. And really at this stage, we're starting to think about quality of life, not quantity of life. So starting to have those discussions about hospital, avoiding hospital unless we really, really have to. We know for someone living with dementia who's in a routine, who's in an environment that they know, with people around them that they know, even if they're not recognizing some of those people anymore, it's very different to then being in a noisy, bright environment with, different people who can't recognize necessarily what their care needs are, don't know them as well. There's other noises around, and it really can be quite distressing for the person who really doesn't understand why they're there. So we certainly want to avoid that if we can. Did you want to say
Well, the
anything
next
more
slide,
about
Karen,
deprescribing?
yeah, that's right. Yeah, so just still on preparation, deprescribing. Some of this may have already happened in stage 1 and 2 with dementia. I had a lady the other day who was probably sort of stage 1 heading to stage 2, and she's 91, and she was on a I just saw her for the first time the other day because the other GP was away, and she was on a statin as primary prevention. And we had a bit of a yarn about that, and she wanted to reduce her pill burden, and the benefits of a statin in primary prevention in a 91-year-old is very, very well. The research doesn't really exist, but we know using statistics that that benefit's extremely low. So she was happy to stop that. So you may have already stopped some of these other medications, and there's some great tools that you. There's another PHN in Tasmania that's got some fantastic tools for stopping medications. It's not on the screen there. We've got some other ones, but we're doing a medication one on Thursday night. So I know about Tasmania PHN. I'm happy to give them a shout out. And probably the other one to talk about tonight, probably just briefly, would be, considering talking about dementia, is the anticholinesterase inhibitor, donepezil, and when to stop that. So that's a challenging question. That the risk about stopping donepezil is sometimes people have a rapid deterioration in their cognition that maybe it was providing, and that when you restart it, that won't come back. So that's the risk. The benefit might be they might be having some side effects from the donepezil that you weren't aware of, such as gastric side effects or risk of falls. So again, there's no particularly clear answer to that one, but I'd suggest if we're heading into the last stages of palliative care, then definitely if the person's lost all quality of life and the aim is comfort, not to extend life, then that's certainly a time you could be considering stopping that. Or of course, they can't swallow their medications. That's another opportunity.
And your medication reviews can be certainly useful. I've had a couple where I hadn't noted really that, due to their significant weight loss, suddenly things like paracetamol, actually a normal amount, was too much. So using your medication reviews to assist with thinking about some of that medication burden can be really useful as well. There's a question in the chat, Pete. Stage 3 can last for years, can be in palliative pathway. When is the right time to get crisis medication prescribed? When they commence a palliative approach, or wait for end of life? And that's a tricky one.
Yeah, I don't think there's a right or wrong answer for that. It's funny, the word palliative, isn't it? Because as soon as you use the word palliative with a patient, they have a particular association with that word, which is, okay, that's it. I'm going to be dying in the next week or two. It's a common response, as I'm sure you've probably seen, whereas the way we think about palliation is far different. So yeah, that's one thing, just to be careful about how you use the words. But I think earlier the better. If it's just sitting on a med chart as a PRN dose, if you're concerned, if you're thinking, geez, this would save me a phone call at 3 o'clock in the morning, that's not going to hurt to have it there. And it doesn't take long to write down 3 or 4 medications, some morphine, some some benzos or some hyoscine or whatever you want to prescribe that's in your arsenal for regular end of life symptoms. Is that your approach, Karen?
I certainly would have it there very much at the end of life. But if I'm seeing somebody that is, bedbound, chairbound, no longer able to talk, having any of those kind of swallowing difficulties, or certainly any of those other kind of poor prognostic sort of indicators around, maybe some pressure areas, weight loss, then I'm definitely going to be starting to discuss it with family and thinking about having it there just in case. And again, if you've got good instructions about when to use it, you may well just sit there on the PRN chart and then until it's next updated without it actually being used, and that's okay. We're really coming down to trying to prevent those, more futile hospitalizations, and being able to provide comfort should it be needed on, midnight on a Friday night, because inevitably it's not during the day, it's overnight or when the locum staff are on. So having that ability to have something in the toolbox can be quite useful. And just because it's used doesn't mean suddenly things change either. I've had on occasions, for one of my patients with dementia who'd had some significant shortness of breath overnight. So the staff had given her, because it was in her, a little bit of morphine. It all settled. We then gave her a bit of Lasix and she's still, 6 months later, she's still here. So it doesn't necessarily mean that's end of life, but it certainly did save her being put in an ambulance and transferred to hospital, which had happened the year before. So then we come down to that communication stage. So really looking at thinking about discussing that with the carers, both staff who are looking after if in residential aged care and the family, extended friends, the carers around them as well, if it's somebody that's living in the community or in residential aged care. And the more you've had those discussions over the course of somebody's journey with dementia, the easier in a way it is, because families know that it's coming. So it is certainly something that it's much easier to have these discussions before an acute event than in the middle of, families are rung at 12 o'clock on a Friday night and ask what they want to do. So it's much better to be able to have these still difficult conversations, but at a time when there's actually not much happening. And I usually talk about the difference between, that very slow decline that we might see that might go over months or years versus something happening quite quickly, and that there's no way of predicting which way, mum, dad, brother, sister may end up going. But it is something that both options might happen. And really that shift to, what does a person, what did they like? What would they want? We really want to think about quality of life at this point and comfort. And certainly having those discussions around CPR or those sort of things at this point is much easier, and families are much more likely to say, no, I don't want it, where I've found without having that discussion about really quantity of life versus quality of life, families are much more likely to say, oh, I want everything done. So having those conversations often changes some of that. Were you saying something, Pete?
I was going to say, yeah, I think it's important to consider too that, like, at the end of life, with dementia, it can be presented. It can happen in different ways. So, we talked about that it's a terminal illness, and in some people it presents as like a sort of multi-organ where they, the brain sort of withdraws, they stop communicating, they stop eating, they stop, their brain just goes into like what you'd call heart failure, you might call brain failure. I'm not sure that's the best word, to be honest, but that's the way I think about it. And they just stop eating, and they, they have a quiet death, which is fairly easy to manage. But then sometimes people who have problems swallowing as part of their dementia, which is quite common, they may end up with an aspiration pneumonia. And then so you're looking at palliating a kind of quite a different death around, respiratory distress, because you're not giving them antibiotics and oxygen and those kind of things. So just having that, I think, preparing and thinking about how those things may happen, and the person in front of you, can be helpful too.
And then we move on to that very much more terminal phase, where I'm sure for many of you, you will have actually managed this kind of very terminal phase of somebody's life, whether they have dementia or another condition. And really that's when it starts looking more similar to what we might think about, that decreasing level of consciousness, either no longer able to eat or drink, or really having very minimal, really having difficulties with their tablets responsiveness, very much that terminal phase. And again, at this point, we're not always correct, but we usually can predict that we are in the terminal phase. And sometimes, people do recover for a time, because we've stopped their medications that we're poisoning them with. But often once we get to this point, it is obvious that, somebody is moving into that terminal phase. So then again, we can think about those preparations. So we've predicted it, and then we can prepare for it, which probably is similar.
You definitely want to have the PRN medications at this stage.
Yes, absolutely. And at this stage, we're thinking about stopping anything that's not essential at all. And, there's not too many things that are essential at this point. So really we can stop most of them, if not all of them. We do know that there are some people living with dementia who do die at home, and we certainly need to help our families with this. If somebody is in residential aged care, there's often, more staff and equipment and availability around them. So certainly if somebody is still at home, it certainly can be quite difficult for families if, again, they don't know what to expect. So that education around what it might look like, what they need to do, and having that written down somewhere so that, again, when it's in the middle of the night or something's happened, they can go back to that sheet. And some of those simple things like what to do, who to call, how long can you wait before calling, those sort of things that, again, going to be a little bit different from state to state. But as long as the person who is likely to be at home knows what to do, that's the main thing. And then obviously we are going to continue to look after those families, particularly if they are also our patients. So we just want to recognise that it's not as common as seeing people in residential aged care by stage 3, but we certainly do. Some cultures prefer to have people living at home, and some people from a family side of things or carers are able to manage that 24-hour care. And the specific end of life symptoms really are probably the same as you see with many other conditions. We are starting to think about nutrition, hydration, pain, nausea, vomiting, shortness of breath, agitation, and those rattles. That probably the main difference with dementia is just being aware, because of their communication challenges by stage 3, that they may not be able to let you know that they're in pain. In fact, they might be non-verbal by this stage, and often people are. So really thinking about making sure your staff are aware of how to look for signs of pain. And they sometimes will use some of the pain scales, like Abbey pain scales, but being aware of those behavioural things that might occur when somebody is in pain because we can't communicate. And so often I start thinking at this point, do we need regular medication rather than PRNs? If somebody can't communicate as well, or if staff aren't as aware that there may be an issue with pain, then actually making things more regular can be a way of getting around that. Did you want to say anything about nutrition and hydration, Pete? I'll hand it over to you.
Yeah, thanks, Karen. So again, a conversation that really needs to be had with family, because there's often pressure around them concerned that their loved one is thirsty or hungry, but in these final stages, we can make things worse. So if they're still able to eat and they're not aspirating, they can have easy to eat food. It's a lot of my palliative care patients' blood sugars tend to go up quite a bit.
Don't check
the
them, and then
care
you
phase.
don't know.
Ice cream and the nurse got to tell the nurses not to check the blood sugars. Seems to be very popular. So, but really just having that early discussion around how to keep someone comforted, by they can sucking on an ice cube or keeping their lips moist and these kind of things, but not needing to put down a nasogastric tube or put in intravenous fluids. Specifically important. Yeah, and then we've got another point there, which I think is very important too, around if discussion around people have religious and cultural backgrounds and beliefs, and having a think about, or talking to them about how that may affect what you're going to be doing.
Yeah, and certainly it's interesting. Families can get quite fixed ideas about food as well. I've certainly had someone, and her mum was 99, and she was really concerned that all she wanted was ice cream. And like, she wants to eat ice cream, that's fine. That is what she enjoys. That's all she wants to eat. It's actually okay. And being able to, again, spend some time just educating and spending time with families certainly can help allay some of those fears that, their loved one is starving or thirsty. But actually, that drivers of appetite and thirst often do disappear as dementia progresses. There's a question in the chat about some of the symptoms of pain in a non-verbal person. So certainly we're looking out for things like grimacing, flinching, maybe there might be, some groaning or some of those vocalizations. Anything else you can think of, Pete?
Yeah, no, I think that's what I was thinking. Yep.
I was just looking up quickly for you the Abbey pain scale to see what else is on that, which you can just Google, but it is specifically made for residents who can't verbalize. So yeah, they've got changes in body language, facial expression, physiological changes. Often we're not necessarily going to be doing blood pressures and pulse rates at this point, but certainly that might be something that staff want to use as a measure. I often stop doing a lot of those physical observations because I think, again, it can be distressing for the person, but certainly looking out for, particularly that kind of grimacing, groaning, flinching, or being very resistant or becoming more agitated or upset around, say, cares, for example.
That's a good segue into the next slide, Karen.
So
About
again, if we're
management of
thinking
pain.
about earlier in stage 3, so before somebody is very much at that dying in that last kind of days to weeks, then we can certainly think about some of the other modalities of pain relief. And again, I would be looking at that regular pain relief when somebody has moved into the stage where they are non-verbal. And that can be anything from simple heat and massage through to your simple analgesias, through then to some of the more, things like opioids, etc. If you thought somebody was in significant pain. And again, we know that certainly from some of the other chronic conditions that people have, whether it's arthritis or contractures or other things, there may actually be an element of pain. And so again, that's often when we see somebody who is quite agitated and nonverbal in that stage 3, it's always worth making an assessment for pain. And often one of the common spots is under dentures. So I always make sure they pull the dentures out because it's really common to see ulcerations and things as somebody's lost weight. The dentures don't fit, and then that causes pain and agitation. But if we see that agitation settles with simple things like paracetamol, then we know that there was an element of pain that's part of it. Obviously, as we move towards that very end of life, then we might be, oh look, I even have that there for you. I forgot I put that in. So that's the Abbey pain scale that nurses in residential aged care can use. And again, it's a way of being able to monitor, are there things occurring or not, and giving them something very specific to look out for. So I think, again, thinking about pain, often once we get to that very end of life, I would be thinking about using things like morphine as either a PRN, or in my residential aged care home, my staff are very used to using syringe drivers, so that might be something that I can use in those very terminal stages as well, just as part of comfort measures. When we come to dyspnea, like many other conditions, really we're looking at some of the non-pharmacological things first, which can make a difference. So fans, moving position, and really oxygen tends to make everybody else feel better. So I certainly often will find our nursing staff will be like, oh, their SATs are terrible, so they've put oxygen on, it's made it much better. Probably hasn't actually made anything change particularly, but staff and family feel better. So if they want to use it, that's okay, but really it's not necessary, put it that way. And again, if we're really finding that that's becoming distressing, then we can certainly use things such as opioids or our benzodiazepines, either as PRNs or as part of a syringe driver to manage.
Karen, I've got a question about oxygen for you.
Sure.
So if you're already oxygen dependent because you had end-stage COPD or, that sort of thing, do you leave the oxygen on?
Yeah, I usually do.
Yeah.
and the families will expect it to be there as well. And part of it is at this point, or in fact, I think a lot of it actually is managing families and carers as much as the person in front of you. So it's a big part of that kind of managing grief and education and keeping them up to date is really letting them know what's happening, but also managing their expectations as well.
Yeah.
Agitation, again, certainly can be part of that end of life, and we certainly do see that, and whether that's due to being a bit hypoxic, whether that is due to pain, whether it's due to the dementia itself, we certainly can see agitation. And again, we can use pain relief if we think it's that. We certainly can use things like haloperidol, which is what I tend to use in my syringe drivers, because that then covers nausea as well. So just dribbling a little bit of that in can make a big difference to just how settled or not someone might be. So again, that's certainly can be distressing to the person themselves and to their families. So we really want to make sure we treat agitation well.
And the non-pharmacological treatments for agitation are useful too sometimes, Karen, aren't they? So thinking about what the person was like, that, you know, and the sort of things they were doing before they were in their terminal phase. So if music was something that calmed them down, making sure you've got music going, just thinking about if there are any unmet needs, you know, have they got a, you know, is their bladder in retention or something like that, or
yeah, or are they wet,
something else
or
going.
yeah, and that
Yeah,
can be a
yeah,
reason as
cold.
well.
Yeah.
Is there a way of identifying terminal agitation versus dementia behaviour changes? Usually we're looking for everything else with it. So if we've got somebody that is relatively well, they're still eating and drinking, they might be bed-bound, chair-bound, incontinent, so certainly in that stage 3 and agitated, I would certainly be looking more at that as being part of the dementia journey rather than necessarily being end of life agitation. If you're seeing it with that reduced periods of consciousness, you know, really having very little to eat or drink, or none at all, and you see some agitation, then I'd be starting to think actually, you know, so we're really looking for clues, other clues that might help us determine which of those they are, but they may look similar otherwise. So, you know, agitation where somebody is very unhappy certainly can look similar, but we're really looking for those clues of, you know, are there other signs that they're end of life rather than just, you know, a need that they're not able to have met earlier on in stage 3. And as Pete said, often that is what it is. If somebody's lost the ability to communicate, they still can feel wet, hungry, thirsty, you know, cold, lonely, all of those sorts of things, but are unable to verbalize them. So one way sometimes we see the expression of that is agitation or calling out, or so really looking at that, you know, what's around it is certainly useful.
Good question, Karen. We've got an excellent engaged audience. I like that one.
Absolutely.
The terminal, the next slide's about the terminal rattles. That's another phrase. I'm not quite sure I so like that one, but we all use it. So, and I think we know what it means, which is really lots of sort of upper airway secretions that are creating lots of noise. And again, like you said before, often at this stage, the person is unconscious and probably not really aware of what's going on, but the family's extremely distressed, and so in some ways you're also treating the family's distress, which is okay. There's nothing wrong about that at all, and as long as you're not doing the person any harm. And I mean, Hyoscine's the drug that I generally use, and yeah, I've got some doses there for you, but that's pretty common practice, I think. Maybe repositioning may help if it's an upper airways thing, depending on the reason of the noises.
So most of those are pretty much the same kind of palliative care toolkit that you would have for any condition. It really, particularly the pain and the non-verbal, is the one thing that is different, but the others are very similar to what you may see when you're treating other patients in that sort of palliative care journey. As Pete mentioned before, we certainly think about mouth care, and sometimes just that moistening of the mouth can make somebody more comfortable. We do want to think about that personal care. Is it distressing? Is it something the families want? So again, just thinking about how we manage some of those things. We do want to think about pressure care as well. And again, we may well see more pressure areas as somebody does move into that terminal phase. Families and nursing staff get very fixated on bowels. At this point, usually I just go, they're not eating, they're really not drinking, their bowels are not going to move. It's okay. We're not going to be giving Movicol or Coloxol or anything else. So really just being aware that unless the person is distressed, with a distended belly, we really can ignore the bowel charts at that point. And then thinking about, were there other wishes that the person had in their advanced care plan around, that spiritual care? Would they want, a priest to come? Is there something else that the families actually are, wanting in that very end of life care? And this is where communication is absolutely key, and really, as we've already alluded to, it's managing those family expectations at this stage and educating them about what's coming and what's coming up. So really having that opportunity to discuss, what they're thinking about. And we know, and we've all, probably had somebody that comes from interstate or overseas or isn't so involved that suddenly it can be quite challenging at this stage. And I think grief does bring out the worst in some people. But again, it is something that we need to just help them manage. So it is something that there's a whole range of reasons why that may actually occur, but really being able to spend time with people is what makes a difference. And being able to document that you've had those discussions, that what you and family have actually decided becomes quite important. Anything else you want to add to that, Pete?
No, I think that's a good summary. It can the interstate overseas family member at the last minute can be a challenge, but the flip side to that is also that death can also be a moment where it brings families together. So it can also be in some ways, um, a, well, the word's good, but a blessing in disguise is what my family would say. So it's not always like that. Yeah.
Yeah, absolutely.
I think the next slide is just to reiterate to remember about people from different cultural linguistic backgrounds. And certainly, I'm pretty good at understanding my own family, spiritual and religious and belief systems, but I wouldn't have, claim to know anything about anyone else's. And so I think for me, the question is just keep asking and making sure that you're doing what they need and how you can help with that. And that includes I do quite a bit of work with Aboriginal and Torres Strait Islander people as part of my job, and that extends to that population too. And if you can, getting Aboriginal people involved in their care, particularly health workers or family members who can give you some guidance if there's anything that you can do to assist.
So there are heaps of resources out there, just in general with palliative care, and certainly, and I believe the care search is now live instead of it being called Palliaged GP. There is palliative care pocketbooks, and certainly through therapeutic guidelines, if you've got access to that, there's certainly lots of helpful information about both medication and symptom management. If you don't have the opioid calculator, definitely worth downloading it. It's great for um, any of your patients that are on any sorts of opioids in being able to help you convert between orals, subcutaneous things, and that's definitely worthwhile getting if you don't have it. We do have some resources in the Dementia Training Australia website for GPs specifically, and there certainly is through our Dementia in Practice podcast. There is definitely a palliative care episode as well, and it's a deeper dive into lots of things around dementia care. So right from early in the journey to things like driving, younger patients with dementia, through to palliative care. So that's definitely worth having a look as well, wherever you get your podcast, if you're interested in doing a bit more of a dive into dementia. So really our take-home message, and we do have a little bit of time for questions if you have any more, is that we actually can be that integral part in somebody's journey with dementia, which we know from the word go is a life-limiting journey. So really thinking at all steps along the way, where are we in the journey? What can we predict at this point? How can we help the person and their family or carers prepare? And then how do we communicate that so that everybody's on the same page and have the same goals? Let me just stop that share. Any other questions at all? If not, we'll hand it back to Rebecca.
Thank you, Karen and Pete. That was a great presentation, very insightful. Now we want to wait maybe a minute to see if anyone wants to put in any questions, and then otherwise we'll move on. Okay, so our next presentation is preparing for an expected death, understanding grief and providing support in bereavement. This is going to be presented by Brendan Myhill, who is an end-of-life care coordinator at St Vincent's Health Network Sydney, and is a co-convener of the New South Wales ACT network of palliative care social work in Australia. Brendan has an extensive clinical background in palliative care social work, both within inpatient and community settings, and is passionate about psychosocial care and bereavement, particularly in the way in which experiences in healthcare can shape bereavement outcomes. Thank you, Brendan.
Hi everyone, thank you very much for having me, and nice to be with you tonight. So yes, tonight I'll be talking a bit about grief and preparing for grief, how we support our patients and also support their families. I'd just like to echo the acknowledgement to country already made. I'm on the land of the Gadigal people of the Eora Nation. Pay my respects to elders past and present and any Aboriginal people online with us tonight. I'll be talking about some research as well that was undertaken in Sydney Local Health District, and that is on the land of the Gadigal, Wongal and Bidjigal people. I'm sure you're all pretty familiar with the concept of grief. I won't labour the point, but essentially grief is just a normal, healthy and adaptive response to any kind of loss. And so that might be in the case of bereavement, grief following a death. But when we're supporting a person who's maybe received a diagnosis of dementia, they might be experiencing grief from the time of diagnosis, and there's a lot of experiencing anticipatory grief as well. So although it's a universal experience that many people experience following a loss, every individual's way of experiencing their own grief is quite unique. One of the big things that bereavement counsellors emphasise is there's not really a right or wrong way to grieve. It's really about how that person experiences it and whether their response is helpful and adaptive for them as well. It's important to note that grief doesn't have a timeline, and so there are sometimes challenging attitudes that people around, you should have maybe moved on, for want of better words. And that can be also maybe quite an alienating experience for someone who's grieving and feeling like they're being judged for the way that they're grieving as well. And we know that grief is a multifaceted, quite layered experience. So some of the elements that someone might experience when they're experiencing grief is, probably what you might expect, the emotional aspects of grieving. So the things that usually, stereotypically might think of when you're thinking of someone who's grieving might be sadness, despair, visible evidence of that crying and things like that. Anger is often another significant component of grief, or guilt. Very often, I think I'm talking
Sorry,
about
Brendan,
bereavement
to
here,
interrupt. Sorry,
cognitive and
Brendan.
psychological.
Sorry, you're just
Yes.
cracking up a little bit. Did you want to maybe turn off the video, your
Oh,
video,
sure.
and then see if that's a bit better?
Yeah, sure. Let me try that. Uh, Let me know if that doesn't help. Um, So people also experience physical symptoms with grief sometimes. So that might be things like body aches, headaches, loss of appetite, sleep disturbance, a whole range of bodily experiences. And so someone might go to see a bereavement counsellor and talk about not feeling as they would following a death. Maybe not connecting with the emotional experiences that they thought they might be having, but they might be talking about things like that, not sleeping, not eating, those other kind of changes. So their grief is presenting in a different way. There's ways that people experience grief in terms of interpersonal, social, cultural behaviors, similar as well to spiritual beliefs and practices. For some people, those are quite safe ways to experience grief and quite supported. So if you're part of a cultural group or a spiritual community, there are often lots of beautiful parts to that where there's a collective experience of the grief in a way that people know to support one another. Often the flip side can be true as well, where a person may not be maybe connecting or getting the comfort that they thought they might from their existing spiritual practices or prayer or attendance at a faith community. And that can be a secondary loss for the grieving person as well, that they've maybe lost their connection to a faith or their comfort from that, and they've also lost, whatever it is that they're grieving as well. And then there's the big existential questions. So why me? Why them? They're the questions we can't really answer, but we give people a safe space to explore those thoughts for themselves. Going into some of what we know through the literature about what factors might influence the way someone grieves, especially after a death. So the top areas that often come up in bereavement counselling and in the research around grief as well is if the death was prolonged. And so, having heard Karen and Peter talking about that potentially very long stage 3 experience of someone's death, that might be a significant impact for someone who is caring for a person living with dementia. And so that preparation can be really important, talking about prognostication and what to expect, so that the person is aware that, yes, there may be an acute event and things may be quicker than expected, but for many people, this is quite a long experience. Perceptions around suffering are probably maybe some of the most significant things that impact on a person's grief following a death. We know that from what people talk about in their sessions with bereavement counsellors. And I loved hearing Peter and Karen talking, because all of the communication early on about what to expect at the end of life can really ameliorate that perception of suffering, because it's really there's I guess what we might view in palliative care as what a normal dying process might look like, and what we as health professionals know and expect that a death can look like. For many people, this might be the first time that they've seen someone dying or in the terminal phase or in that last stage of their life. And so reassurance about the symptoms and things that they may witness, talking about the rattly breathing and things like that, and letting someone know ahead of time that these are possibilities and what we can do to support those symptoms can be really important, so that they know, oh, okay, the doctor mentioned that there might be that rattly breathing. I can ask the nursing staff to maybe help with repositioning. I can ask for medication. That can really support that person's experience in that moment. lack of shared decision making is another thing that comes up a lot at end of life, where people don't feel that they are consulted or included in decision making. And so going back to what Karen talked about in that kind of stage one of using that diagnosis as a trigger point of, have you thought about what kind of care you might want in the future, who you want helping you with your decision making, can be so important in terms of laying the groundwork for the later stages where the person might not be able to communicate for themselves. And then connected with all of those topics is lack of preparation for the death. And so acknowledging early on that a diagnosis of dementia is life-limiting, and laying the groundwork over time, small bits of measured and dosed information over time, taking into account the person's communication style and how ready they feel to take information on, and knowing that it won't be one conversation, it might be many conversations over time that help with that preparation. There are other factors that influence, so in terms of close relationships to the person who died, and so you may, see that in terms of the heavy presence of carers, and that can sometimes be a flag that hey, this might be a beautiful and loving relationship, but also that this might be an especially significant loss for the person after the death. There are considerations around attachment style, and we've mentioned religion and spiritual beliefs and practices. Other things that can be quite significant is treatment-related factors. So it comes back again to that preparation and shared decision-making. So aggressive medical intervention at end of life often has negative implications in terms of bereavement. So having mapped out early on if there's agreement around avoiding non-beneficial interventions can be so helpful. And it can also help with anticipating some of those conversations, hopefully helping to avoid family conflict and caregiver burden as well. And then there are factors around death itself. So if you're meeting a person who's caring for a person who might be dying with dementia, and you're aware that they've also had other deaths and other bereavements, that's a bit of a flag that this might be someone who needs some extra support in bereavement. And then also there's research around, it talks here about finding or viewing the person's body after a violent death. I think maybe more significant here in terms of dementia is thinking about what a family member may want in terms of access and interaction with the person's body following a death. And so is that something that's important to them? And so it might be worthwhile, if there's an appropriate context in a conversation, to ask them about what's important. Would they like to be present if there's notice? And we know obviously things happen often quickly, and we may have no warning that if someone is right in those last hours. But also giving people permission. So if it is a home death, preparation about what to do, and knowing that they can take their time and have more people attend the home and still hold the person's hand and talk and interact if that's what feels right for them as well. And then from the reverse side, in terms of resilience factors that may help a family or a bereaved person following a death, is someone who you can see is drawing on their past experiences. Often this won't be the first time that a person has experienced a challenge in their life, and so they might be able to reflect on what are the coping strategies that help them get through those experiences in the past. You can see them maybe connecting with their support network, drawing on religious or spiritual practices, and they know their own strengths, or maybe they can work with you to identify those strengths that they can draw on now. And have higher practical levels of practical help. And what is really helpful is where you can see people accepting offers of support and offers of help. And often the best practice there, when we're meeting someone who's evidently accessing their internal resilience and accessing other support, is often to step back and not try and replace something that's working well. So we don't need to step in and be their main support person, because they're accessing those internal strengths and their informal network. What we do is there, as Karen and Peter were talking about, is that excellent communication and giving them information that they need and helping them plan ahead. So I wanted to share some results from a research project that I was a part of in Sydney Local Health District, but not research is often not a solo activity, and so just acknowledging my co-investigators there on the screen. So the primary objective of the study was to understand the bereavement of people bereaved after a death in Sydney Local Health District. And then we looked at a range of other factors, including their experiences of advanced care planning and the impact that healthcare interactions had on their bereavement experiences. And so to do that, we had a survey that was sent out to just under 2,000 people who were bereaved following a death in the health district. People are listed as next of kin. There were 293 surveys returned, and then some people also consented to take part in an interview. We recorded and transcribed those and analysed those with a thematic analysis approach. And I should note that these results aren't specifically about people who died through dementia. It was a range of diagnoses from across the health district. But one question we asked people was, did your health providers help you to understand what to expect or how to prepare for the person's death? About 35% of people said definitely, which is really positive. 39% said to some extent. I think the concerning gap here was 22% of people who felt that they didn't have that information. The people answering these questions as well were from a range of settings from across the health district. So some of those were in hospitals, in ED, ICU, palliative care, lots of different ward settings, but with community palliative care at home and also in residential aged care facilities. When people said that they were told about what to expect, we asked them about what they'd found helpful about those discussions. And some of the things people talked about finding really helpful were understanding the process of dying, so what to expect and what dying looks like, knowing about their care options and really feeling that reduced their anxiety and fear. People spoke a lot about valuing honest discussions and receiving clear information. And I think there's lots of research also now supporting that is often the case in maybe cultures or for people from countries where we may not have previously expected that they would want that frank information. I think it's just a highlighting, though, of how important it is to ask someone about their communication preferences and how much information they want, or whether there's someone else who is appropriate to provide information to. People valued reassurance about pain and other symptoms, and what came through really strongly as well was staff showing empathy and care and how important that the tone of discussions was. Some of the things that might help, resources in terms of what might help supporting a family or carer to understand more about the dying process and what to expect. So you can have a look at the Palliative Care Australia has fact sheets about the dying process. Dementia Australia also has information. And there's a great webinar that you could take a look at, which is about palliative care and dementia as well. The link's available there. Just touching again on cultural considerations, it's really hard for any of us to know the experience of being part of another maybe cultural group, or even to assume if you are part of a cultural group that another person's experience will be the same and what they need is the same. So the approach here is very much about not making assumptions, being respectful, and I think most people are open if you approach them with a curious and open, interested way. So asking broad questions initially, maybe just, maybe like what's important to you. And so that might elicit things about culture or spirituality, or it might bring up something else that's really important for them that they want you to know about. Or it might become more specific in terms of, is there anything you can tell me about yourself or your culture that will help me look after you better? Coming back to the findings of the research project from Sydney Local Health District, we asked bereaved participants whether prior to the death had any healthcare worker spoken with them about the grief that they may experience after the death. I was surprised at this, so the numbers were quite low. So only 17.9% of people, so just under 18% of people, said that a healthcare worker had spoken with them about grief prior to the death. I expected that maybe that would have been a bit higher. And coming from my background is in palliative care, and I feel like, we talk about grief a reasonable amount. And I thought, oh, okay, maybe if we broke it down and just looked at the deaths of people who died within the palliative care setting, would that be different? And it wasn't significantly different. And I was quite surprised by that, and concerned. What I found very helpful to understand, though, was of those people who did have a conversation about grief before the death, we just asked simply, was the discussion helpful? And it was quite overwhelming. 86% of people who had that discussion about grief before the death found that to be helpful. And I think those don't need to be very long conversations. They don't have to be particularly complex. Often it may be just about acknowledging the distress that you're seeing. You could perhaps name it as grief. I can see this is really hard. I can see that you might be grieving at the moment. And that might lead to a discussion about what support the person might want to access in advance of the death and their experience of anticipatory grief. Or it may be about acknowledging that they may also require support in bereavement and mapping out what some of those supports could be. So some resources that are quite helpful in terms of grief. Grief Australia have a lot of great fact sheets and resources, so you could take a look at those. The National Dementia Helpline as well is a great source of information and support. So they provide emotional support and guidance. They connect people to other supports and programs and information as well. So it's well worth taking a look, which can include a person with a dementia diagnosis reaching out for connection and information as well in their own experience of potential distress and need for support. And then another really helpful option is the Carer Gateway. So Carer Gateway, amongst other things such as respite, practical supports and information about carer entitlements and things. Carer Gateway also provide free counselling for carers. So they might be able to access in-person one-on-one counselling, in-person group counselling, or phone counselling as well, depending on their particular situation and what they need. They have other online skills courses and fact sheets, and as I mentioned, they provide respite and tailored care packages at home as well. And then coming back to the research project data, we asked people as well, so these were people who'd been bereaved, what type of support would have been helpful to have gotten from a health clinician after the death? Overwhelmingly, the top response was a follow-up phone call. And then people talked about practical information about what to do after the death and written information about grief. We asked people as well, so did they receive a phone call after the death, and did they find it very helpful, somewhat helpful, or not so helpful? And it was quite strongly evident there that a phone call from a familiar healthcare worker was much more helpful than someone that they didn't know. So of the very helpful phone calls, 88.9% of those came from a known healthcare worker. And in our interviews that we did as well, the role of GPs came through quite strongly there, given the long relationship that a GP often has with the patient and with their family. So people found it quite helpful to hear from their GP after the death, with an offer of condolence or to answer any questions. And also conversely, noted sometimes where it had been a long relationship and if they hadn't heard from the person as well. Just share here, and you can, these slides will be available, so you're welcome to come back to this. This is just a bit of a guide about what you might include in a follow-up phone call if you're contacting a family member after a death. So it can be helpful I just wanted to check in on things, see how things have been going for you over the last few days or the last few weeks. A lot of a phone call of this nature is about listening, and validating what you're hearing. Reflecting back, I can hear it's been a difficult time for you lately. I can hear that this is really hard for you. Asking about other people, do they have support around them if they need? Any questions? So what people also talked about in the interviews that we did was having the chance to clear up any things that they had hanging over them in terms of questions left over about the death itself, about the care that was provided, about what they did as a carer. And people often might need lots of good reassurance about the care they provided. And so that can be quite helpful to fill those information gaps following the death. You might want to give them other information about things like to expect, like when the death certificate might come out. And the other really helpful thing is to map out the available resources to them. So, the bereavement counselling resources for your local area, and also that they can get in touch down the track if they've got questions that come up later. Some resources that might be relevant for you in your area. So Sydney Local Health District has a bereavement counselling service that offers counselling appointments to people within their health district, or people for people bereaved following a death in one of their care facilities at Concord and RPA hospitals. And St Vincent's Hospital Bereavement Counselling Service have a counselling service based at St Vincent's for people who died in their local area as well. Centrelink also have some quite useful information about the practical things for following a death as well. And if people can't access one of those bereavement counselling services, and I am aware for both of those counselling services that I mentioned that they've got waiting lists at the moment, and so people might want to look at other options. One really excellent one is Griefline, which is a free service that provides telephone support. That can be individual counselling or group counselling. And that's all forms of grief. So it doesn't have to be solely a bereaved person. It may be a person who's experiencing their own loss because of their, maybe early stages of dementia, and if they're processing that, they can also phone Griefline to access support. They're not a specialist dementia service though. And the other is Carer Gateway that I mentioned earlier, which is can be a support for carers when they're providing care for a person, but also following their death, they are sometimes able to provide bereavement counselling as well. So thanks very much for listening, and sorry that I haven't been able to have my video on for you. My contact email is there, so you're welcome to reach out following this as well. But I might stop sharing my slides and pop on my video just in case anyone has any questions as well.
Thanks, Brendan. That was great. It's very insightful, the data from your research project. Very interesting. If we have any questions, we'll wait for a minute or two to see if they come through. Otherwise, we'll move on to the next. Thank you, Brendan. Do you need anything else? You're good? Okay, so we've got a final 5-minute presentation, and that's going to be presented by Dr. Diane Madovic, and she's going to be speaking to Professor Simon Wilcock. They are presenting on an Aging Well tool, which is a dementia risk reduction tool in primary care. So Dr. Diana Madovic is a postdoctoral researcher and a member of the Macquarie University Lifespan Health and Wellbeing Research Centre. Dr. Madovic manages wellbeing check tool designed to screen the risk factors in dementia and poor well-being, for example, depression and social anxiety in older adults in primary care settings, and provide evidence-based recommendations for risk reduction. Thank you. Have we got Diana there? Simon, we can't hear you.
Yep, I'm here. It looks like Diana might be frozen, so I might try to. Can you put up her slides?
Yeah.
And my camera on. Can anyone?
You're breaking up a bit, Diana. Let me get the slides up.
Hello, can everyone hear me?
We can now,
Yes.
Diana.
Oh, good. So I am having internet issues, so I will keep my camera off. Sorry about that, everyone. So let me just pull up my slides. So yeah, as Rebecca said, I'll be talking about our Aging Well tool that's designed to improve the detection and treatment of risk factors for dementia and poor well-being in older adults aged 60 to 70 years. So there's a lot of evidence now that there are risk factors for dementia that can be reduced, and recently released her Lancet Commission review showing that 45% of dementias worldwide can be prevented if we eliminate 14 risk factors. And so like the 45 to 49 year check and the 75 plus check, our vision is a 60 to 70 year check to set older adults up to age well. It's been co-designed with GPs like Simon, older adults, and the Sydney North Health Network.
The bottom line here is we'd like to enrol practices who'd be happy to recruit patients for this study. We've done this in my own practice and found that the refusal rate was very low. Most people in the 60 to 70 age group are very happy to participate in what's essentially an easy iPad questionnaire to determine whether they have risk factors for dementia. But I'll hand back to you, Diana.
Oh, okay, great. So yeah, so basically there's the baseline, the 6 and the 12-month measurements. Patients are given scores, and that's compared to clinical cutoffs for dementia risk factors. And that happens immediately for one group or at 12 months for the other group. And then their health is tracked across the year. So they get all their health data at 12 months. Evidence-based recommendations are provided to the GP, and that's tailored immediately or at 12 months, but all patients receive some risk reduction recommendations. So the Aging Well tool measures modifiable risk factors, including depression, anxiety, social isolation, loneliness, alcohol consumption, BMI, fish consumption, diabetes, smoking, blood pressure and cardiovascular risk, cholesterol, hearing loss, falls and head injury risk, physical activity, cognitive engagement, and insomnia. So the first bit is what the patient fills in. So for this, we're asking about their social isolation. They fill in these surveys that are psychometrically valid. And then the GP fills in 5 medical variables, such as this cholesterol variable that you can see. Next slide, please, Simon. So the way it works is practices are randomized. So you're either getting the immediate feedback that's personalized to patients' risk scores, or you're getting a self-help booklet, and their health is tracked over 12 months, and they get the personalized information at 12 months. And so, as I mentioned, there's a baseline screening, the 6-month and the 12-month, and we collect acceptability and feasibility data at 12 months as well. So here you can see an example of what the report looks like. So for social isolation, this patient has a score of 6, and that's in the risk present range. And so you can see they're about midway through. For loneliness, they have a score of 6, and the scale is ranging between 0 to 6, with the risk present range being 2 to 6. So you can see that they're at the very top of the range, and they're as lonely as they can be. You can either look at the risk present, risk absent information. So it's red if the risk is present or green if it's absent. And you can also use the scores to indicate severity if you're wanting to look into that. And then finally, you're provided with a list of evidence-based recommendations, and you can select what you think is appropriate for your patient. And those will come up at the 6-month and the 12-month measurements so that you can see what the patient's done, what's working for them, and potentially work with alternatives if that's better for them. So that's basically it. Simon, if you could just go on to the last slide, please. So if you want to get involved, there's our email. There's also a website for the trial. So Rebecca will be sending these slides out after the webinar. And I think I'm going to take advantage of Simon being here now and ask him a question about his experiences of implementing the tool in his busy practice.
So we piloted this tool, Diana, as you know, in our practices, and where a practicer has 2 different sites. To test how the system went, we allowed up for patients to take up to half an hour to complete the questionnaires, and they're actually doing it on site. We've now modified that they can do that from home on an iPad. And the reality is most of the participants could complete the surveys within 10 to 15 minutes. Refusal rate, as I said, was incredibly low, mainly because when you talk to somebody in the target age group, which is 60 to 70, they generally are very interested in learning about their risks for dementia and accessing information to reduce that risk.
Great. So that's our 5 minutes. I'm so sorry about my internet issues. If anyone has any questions, I'm happy to answer them now.
Hey.
My last comment to GPs, we all find we're time poor and it's hard to implement research in general practice. So this survey has been designed to minimise the workload for GPs.
Thank you very much, Diana and Simon. That was very interesting.
Thank you.
That brings us to the end of the session for tonight. So just let's say a special thanks to all tonight's speakers and everyone who's attended. Just a reminder to please complete the online survey that will pop up on your web browser, and also the post-training survey that's going to be emailed out to you. And we'll see you all again soon, hopefully. All right, thank you.